Well, I want to thank everyone for coming to Nashville. My name is Katie Beckerman, and I'm an assistant professor and GU medical oncologist. This has been a wonderful conference. Thank you to the organizers and, of course, to KCA. And want to introduce this session on clinical challenges and research across both academic and community practices. And I'll introduce Dr. Bhupathi and Dr. Garmezi, who are going to talk to us about how community oncologists conduct clinical trials.
Thank you so much for the opportunity to speak today. My name is Manoj Bhupathi. I'm a GU medical oncologist in Denver, Colorado. I'm also one of the co-leads for Sarah Cannon Research Institute for GU research. With me is Ben Garmezi, who is the other co-lead for GU research, all at Sarah Cannon. He's based out of Nashville, and I'm based out of Denver. Thanks for this to talk about what we do and the challenges from a community oncology standpoint. So, learning objectives. So, what are the challenges in community oncology, and how do we move the needle forward for developing earlier therapies or novel therapies earlier in the community itself? As this group very well knows, clinical trials, advancements in drug research and everything is just challenging, and enrollment into clinical trials has been low, with the national enrollment of around 6%. The NCI-designated cancer centers are somewhere around 20%, community cancer centers around 4.4%, and disparities across various centers is also highly variable. There's a lot of barriers as to why we can't enroll onto clinical trials, whether it be availability, eligibility, logistics, however you want to define them. It basically takes a lot of patience to try to get onto a trial and try to even get the drug approved, going from early stage to approval. It's estimated somewhere around 12,000 patients needed to produce a single FDA-approved drug, but even then the efficacy may not be there with the designated population that's intended. And so when you look at this study, it's actually showed about 39,000 patients that are actually needed in order to really get a substantial effort in order to get a drug that is valid across the general population, and that's across many different tumor types and such. And this is another study that's basically highlighting the point that over the past few years, we've just needed a strong number or high number of patients that needed to be enrolled onto a study in order to even try to get to an actual point of a therapeutic target. And these are just looking at various trials and various complexities and deviations and such that we're actually trying to even complete the study. When you look at phase 2 trials, about only 14% were actually screened and enrolled or even completed the trial in itself. So when you look at community oncology networks, there are various groups of networks, and so you can see here you have the SWOG Alliance, Canadian Network Group, NRG, ECOG. They're all cooperative groups. From a community oncology standpoint, it's actually a little bit harder to do research with cooperative groups, morely from a funding standpoint. A lot of these organizations can get some funding from either NCI or other organizations. In academic institutions, they actually get grant support and such. And that's not always the case in a typical community kind of setting as such. And when you look at across the map on the US, there's about 32 community sites and 14 of which are considered underserved. Highlighting the point here, when you look at this and you have over 100 clinicians and about 4,500 patients that have been enrolled onto sites, and as I was showing you earlier, there's the number of patients to actually get onto a study in order to get a valid therapeutic target is actually much, much higher than that. So where do we come in from Sarah Cannon Research? I'm going to let Ben talk about this.
Yeah, thank you, Dr. Bhupathi, an excellent colleague of mine out in Denver, and again, thanks for everyone coming to Nashville so that I didn't have to travel today. You know, he did a great job of showing how many patients need to go on trial to get a drug all the way from a first-in-human dosing to a regulatory approval, which ultimately benefits the patients. Increasing complexity makes that harder to do, and that's why you see so many patients that get screened actually not complete a trial. Now, I'm tasked with the challenge of now talking about community oncology research and trying not just to brag about the organization I work at, which I'm very proud of. But so this is what we do. We do Sarah Cannon Research Institute. We're over 50 sites across the US. We have phase 1 all the way to phase 3. It's not just Sarah Cannon. The goal here isn't to be an advertisement. There's other community networks out there, and there's others that are expanding to do what we have been doing for years. The point of the talk today is to understand how can we bridge with you guys in academia to actually get drugs across the finish line and bring them to patients, because ultimately that's the goal. And what we've done is we've put 4,500 patients on trials, and the vast majority of FDA approvals have to come through community oncology. Right? And in order to do that, though, unlike at academic centers where you vet a trial from a scientific standpoint and then it kind of goes through different institutional barriers, we have to form our own CROs, essentially our own SMOs, to actually get the logistics of the trial off the ground. We have done this in the community site, and it's helped that we've banded together. So SCRI has grown from 14 sites to over 50 sites because there are synergies at scale here. But we're at a GU conference, we're at a kidney conference, and we also want to talk about a unique barrier that's not just patients, locations, trials, financial dollars, et cetera. It's what are the unique challenges at a community site to actually enroll on a genitourinary trial. In academia, most of our medical oncologists and urologists are under the same roof, under the same institution with aligned financial incentives. You know, realistically, in the community, there are some practices where urology and medical oncology are embedded together. However, that is still rare and still the minority of practices. To run a perioperative trial, to run a trial in frontline hormone-sensitive prostate cancer, these require urology input, and they require colleagues at a different institution from our clinics with a different financial motivation, a different patient population, and an ever-changing scope and landscape of practice. Now, we're not fighting that scope and landscape of practice change, we're understanding it, and we're working out ways to collaborate across subspecialties so that we can help run these perioperative trials and these prostate trials and probably soon adjuvant kidney and bladder trials with our urology colleagues. In order to do that, it takes a lot of paperwork, it takes a lot of legwork, and we have done that to varying degrees of success within our own network. So what we've been able to do in places like Virginia and other places where we've been able to actually partner across different institutions, different kinds of community practices to actually joint run a trial. That means chopping the budget, it means chopping the effort, it means chopping the regulatory. It's not easy to do, but it can be done. And with my pharma biotech colleagues in the room here, we need your help to help so that we can do that. We need your buy-in for this mission to bring drugs into the community and let us do some of these things on trial. And obviously, we also need to continue to work with our regulatory sponsors and the government to do these things too. Now, there's some other challenges too, right? It's not just different practices and dollars, but what can the role of community oncology be? What can we do to help our academic colleagues in the room? There's patients, obviously we see the majority of them in the country. Rare tumors. Some of these patients can travel, but I'll tell you, Sarah Cannon Research Institute and our community colleagues outside of SCRI see these rare tumors all the time. Sometimes you in the room will get emails from doctors in our networks asking for help, but we can help enroll these patients on trial. How can we do these just-in-time enrollments for these rare types where we can, say, run a chromophobe RCC trial in just a very rare subset histology in a patient population in the community? It takes buy-in from all the parties involved, from the people designing the trial and doing the translational science to the regulatory agencies as well as to the sponsors of these trials. So we can do it. It's just going to take some time and working together to make this happen. Dr. Bhupathi and I feel strongly that Sarah Cannon Research Institute and our community oncologists outside of SCRI can help us do this. But also, how do we bring these more quote-unquote toxic therapies to real patients? Bispecifics, CAR T cells, how do we show that we can give that in a community setting? So what Sarah Cannon Research Institute has done, along with some other community networks, is actually embed phase 1 dose escalation sites within a community practice where providers understand how to refer in and out and help co-manage toxicities on some of these patients. It's been a very successful model, and as we start thinking about how do we move some of these therapies in the bispecific space out to real-world patients outside of the country, I think we're poised to help do that and really be a playground for how do we experiment to bring these trials to other patients. And now we're working on these now with obviously many different companies, and we've had leadership in CAR T, but my point also is what else can we do from a molecular standpoint? This is what we can do with something called GenaSpace. And there's other programs out there from other community sites where I picked a prostate, outside of kidney, I know. This is ATM mutations in patients with prostate cancer across the country. We can take a trial, look at a rare mutation, drill down what percentage of patients, whether it's plasma, solid tissue, and help accrue to this trial. So if we want to come up with, in the room, with a kidney-based trial, we can do that. Prostate, GU, obviously outside of GU as well. But we have the ability to have this line of sight from coast to coast to help enroll these trials, which is a bit unique from our academic settings and our academic colleagues, where we can really drill down and place trials intelligently where the population is that can enroll in these trials, so that it's less of a 14% hit rate on some of these early phase trials, but we can get that hopefully up above 50%. So with that, I'll say thank you. I hope that wasn't too much of an advertisement, and thanks Dr. Beckerman for helping lead this session.
I think it's certainly very impressive what SCRI has accomplished, and so wonderful to hear, and looking forward to a great discussion. I'd like to now introduce Dr. Daniel George, who needs no introduction, but is going to talk to us a little bit about pragmatic trials, specifically Odyssey, and how things are changing in the academic setting.
Thanks, Katie. Thank you all. Wow, it's bright up here. I was tasked to talk about pragmatic trials and how trials are changing. I like to think trials are changing. I'm not sure we're there yet. I think what Ben just brought up, though, is really important, and that is that we do need to bring the trials to where the patients are. And so I think our learning objectives today are to really recognize what are the characteristics of pragmatic trials and think about opportunities to do this in the future trial designs for kidney cancer. So this is a nice review if anybody wants to sort of read up on what is a pragmatic trial that came out of New England Journal here. And these are the 9, they call them dimensions or aspects that we can think of when we think is a trial really pragmatic. And I'm not going to go through all of these, but they include things around the investigators and the participants, the eligibility, who we're including and who we're excluding in these studies, the recruitment, where are these studies opening up? How are we accessing patients for this and the settings that we're studying them in? The interventions that we're doing and the flexibility around delivery, adherence, et cetera, the follow-up nature, and the outcomes. How relevant are they to patients? Are these really real-life outcomes, or are these outcomes that we use for regulatory purposes that may not necessarily translate into our day-to-day treatment decisions? So I'm going to give an example here what I think of as a pragmatic trial, the Checkmate 920. It was mentioned earlier. This is a study. Some people call it a phase 4. Some people call it, post-approval trial. This was an ipi-nivo study, but it looked at a different regimen of ipi-nivo in cohort 1, a more drawn-out regimen every 8 weeks of the ipilimumab and different dosing of nivo every 4 weeks. And then it also looked at a number of cohorts that were excluded from this initial pivotal trial of Checkmate 214. So non-clear cell RCC, patients that had non-active brain metastases, and patients with poor performance status. This was in the write-up from our paper on the trial, the first paper on the trial, and it really spoke to the purpose of this. To do a study that was largely in a community-based setting, to really understand how this regimen could translate potentially in a more tolerable way into a real-world context. And that's actually what we saw. We look at the safety for that alternative dosing of a more drawn-out ipi-nivo combination. Do we have a pointer on this? Is there a pointer? There's no pointer? Okay, I'm going to point. It's right there. Up in the corner, you can see the AE leading to discontinuation rate. It's about 19%, almost 20%. That's actually lower than what we saw in Checkmate 214. So this was a really tolerable regimen overall, even in a community setting where our patients aren't necessarily as fit or as selected for as we were in the registrational trial. Unfortunately, these were the efficacy results, and they're less than what we saw in Checkmate 214. We overall saw for progression-free survival a median of 4.8 months. We saw an overall response rate of about 34%, and you can see that 2-year survival of 62% versus, say, 70% in Checkmate 214. So yes, the results aren't as strong, but we do still see a 16%, plateau to the curve here associated with progression-free survival. We are seeing still significant responses and duration of response associated with this regimen, and again, better tolerated. I would argue that 214 isn't the comparison for this study. We don't actually have a comparison because we don't have a community-based data set, prospective data set to compare for the standard dosing of ipi/nivo. We looked in the non-clear cell population, and again, this is a grab bag here. You can see unclassified here representing 42%, probably an overestimate of unclassified. Again, now we're seeing more and more of these subdivided into other types, but we definitely saw translocation in a couple of patients, papillary as well. Again, the results maybe a little bit modest here, but again, we see about a 19% plateau to the curve, so there's some tail to this overall in the population. And then we look at the brain cohort population. Again, these were non-interventional, so small brain metastases that we felt comfortable giving systemic therapy to. And I'll point into the middle table there, table 3. You can see we had a 32% partial response rate associated with this, only 24% progressive disease rate. And that's for the whole systemic body. That wasn't just the brain. And if you look over in table 4, you see the patients with disease progression of their intracranial lesions. Only 25% had disease progression of their intracranial lesions. So really suggests both the natural history of those tumors, but also the ability to treat and control these patients with a pure IO regimen is promising. And those were ultimately our conclusions, that we can give nivolumab and ipilimumab in different alternative regimens. The efficacy may be different, but it's still durable, and it's something I think we can still need to put into proper context. That we can see some, I think, unanticipated encouraging results in untreated brain metastasis, and that's certainly worth following up, and that prospective real-world studies are feasible, and in fact, they're necessary to really understand how patients can tolerate these. But what we don't know, there's more questions we don't know than we do know. How often are we in the real world starting with full doses, and how well are patients tolerating these regimens? Are we restaging often? What are the rates that we do that? How are we managing these patients? How are we managing toxicity in these patients? And are we stopping drug in situations where patients aren't progressing necessarily? So to answer some of these questions, we started a prospective registry. And registries are not particularly popular in cancer. We do them more often in other cancer and other disease types, but in cancer, it's so difficult to do these studies and the resources we have for clinical trials that we tend to not prioritize registry work. And I would argue that's a real problem for us, because I think this is important knowledge gaps in terms of how drugs and therapies and really how patients are living with this disease prospectively. All the retrospective studies in the world will not answer these questions. We need some prospective studies. So this was the goal of this, was to really describe and observe what are the cancer management and health-related quality of life factors that our patients are experiencing with advanced renal cell carcinoma in both an academic and community-based setting. So you'll see our primary objective here wasn't the response rate or the progression-free survival. It's really describing the quality of life, the symptom burden. Yes, we want to understand how these patients are tolerating drug. We want to understand how long they're on treatment, but treatment discontinuation, when they're stopping drug, that's a relevant endpoint for patients, and understanding how we're managing these patients and understanding why, to do some exploratory analyses with biomarkers, both imaging, tissue, and blood, but also to understand the patient experience with questionnaires and to be able to do even physician questionnaires to understand why we're making the treatment decisions we are. The study is very simple. We have very little eligibility criteria, just that they have metastatic disease, no prior therapy, and they're willing to fill out the questionnaires. That at the site level, they have to put in some baseline information on the patient, a blood draw, a physician questionnaire, and a patient-reported outcome. After that, everything's done centrally, really to unburden the site from the burden of doing this and not to compete with the clinical trials that are interventional that are going on at the site. So this can be done without nursing support. And so we're collecting a lot of these outcomes now retrospectively. We prospectively consent them, but retrospectively follow them, except for the physician questionnaire. That's done prospectively as well. In the last few minutes, I just want to point out why it's important for us to think differently about the patients we include in our clinical trials. And we know about racial disparities in prostate cancer and breast cancer, colon cancer and lung cancer, but there are racial disparities in kidney cancer as well. And whether you look by age, by tumor type, by stage, or by size of tumor, Black patients have consistently worse outcomes than our white patients. And they're not included in our trials. They're definitely underrepresented in our studies. In addition, there's a huge geography issue with renal cell carcinoma. This is the United States, but I suppose you could see this in Europe as well, that there is a very, very different rate of cancer mortality to kidney cancer across the country. And this is by county, and this is age standardized. So, and we're looking at probably a difference in blue to red of about 7-fold, 5-fold difference in the death rate from kidney cancer. Now, some of this certainly is the rates of kidney cancer as well, and probably there's more kidney cancer in Texas and Louisiana and along the Mississippi Delta and whatnot per capita. But are these cancers actually more aggressive? Are there differences associated with where these patients live and their mortality to kidney cancer? We don't know that because we lump everybody together. We do a study and we say this is United States and we put everybody together. We don't kind of try to look and see are there differences in how patients are responding or tolerating it. And it's not socioeconomic because this is bladder cancer and another urinary cancer. It has a completely different heat map, if you will, for the incidence in the death from bladder cancer, different from kidney cancer. And so this isn't necessarily, gee, these are just the poor counties or the poor patients or the people don't have access. This is almost a flip of what we just saw. And it really suggests that, we need to understand at a population level what are the differences that are associated with this and driving mortality. So the FDA is giving some guidance. And I say guidance because I don't know that there's a really strong directive here, but they started last year Project Pragmatica. And this is their attempt to help open up the eligibility, help us think about real-world routine clinical practice and pragmatic designs and trials. And it's really part of this effort to really build this into this center of excellence that the FDA has to improve the development of products. These are their 3 objectives, and I would argue they're pretty vague, but I think it gives us at least the framework to start doing things differently, to explore a range of pragmatic elements. How can we design trials differently to be more inclusive of patients, to be more accessible to patients, to bring the trials to where these patients are, to collaborate with all of us, patients, investigators, pharmaceutical companies, government agencies, and policymakers around these endpoints, and then to foster this research potential, whatever that means, to really try to do things differently. I think it's just it's an invitation. It's not really going to tell us what to do. It's up to us as a field in kidney cancer to say how can we do trials differently and be more inclusive and maybe think big, to ask some questions that no one study and no one regimen is going to answer, but that we as a field really do need to understand so that we don't keep missing the differences that might be happening here. So I'll end just the take-home message is that pragmatic trials are underutilized. And when we think of this, we can think of it from real-world studies and prospective registries like Odyssey, but we can also think of it in our everyday trial designs and what we're doing. Phase 4 studies are not terrible. They're actually really important. The first approval of a drug is by no means the end of that development, and we need to do more of these studies, and we need to do them and open them up in populations we haven't studied in the original trials. Thank you very much.
I think we have just a few minutes for questions if people want to come to the mic.
Thank you for a fantastic session. I can certainly attest to the low burden of Odyssey on the sites and the potential great value that it can add to the field. I'm sure majority of us in the room have felt the pain of the regulatory process to activate any clinical trial. And my simple answer to my regulatory team, if Sarah Cannon can open it in 2 months, why can't we? So the general question to all of us here, what is Sarah Cannon doing that we cannot do at academic institution, or how can we learn from your experience to expedite activating clinical trial?
I think that's a great question, and I don't want to throw old colleagues under the bus. No, I think the difference is, at Sarah Cannon, there's one swim lane for all of the GU effort. It is a committee, and it's a simple up and down vote, and we meet every other week. So once we process the trial, we have a ton of employees behind that physician effort to get the regulatory, get the budget, and get it off the ground and get it done quickly. And it's a sheer person volume. The other thing that's unique about Sarah Cannon, unlike an academic center, is that we don't have really intra-institution competition in the same way as, well, different people working on different kidney cancer projects, different people working on different prostate cancer projects. We all have a mission of we're all going to be PIs on this trial at our own separate institutions, and we will kind of divide and conquer on who takes that national leadership for each individual trial. I don't know if you have anything to say, Dr. Bhupati, about that.
No, I completely agree. We don't have the quote-unquote red tape in terms of specific requirements of we need to hit this or that or anything like that. I think from a budget standpoint, it's just much more streamlined as well. We definitely have the support where if we say that we're going to move forward with this, there's a whole team that follows up continuously in terms of where we are, and we have kind of a live update. Like as Ben was saying, we meet every other week. So if we reviewed a trial and we approved it, then we get an update 2 weeks later saying this is where we're at. And so we constantly have these ongoing things. So I don't know that I have anything else to add outside of that.
Do you guys tend to utilize more of master agreements, whether on contracting or CDA level or even ICF level?
Correct. So Sarah Cannon will, for all their sites, if we take say we take a frontline RCC trial and put it at 18 different sites across the country, we'll try to use one agreement.
Yeah, and we have a centralized IRB as well, so it'll go through all of that. And when we're doing the initial site initiation visits, it'll be at the individual site level, but they're all streamlined as well, so they're all narrowed to the same contents for everybody. So.
And thanks. Maybe I'll ask one question to Dr. George, and you addressed this a little bit, but I wonder if you can touch a little more upon, the FDA putting out this call for more pragmatic trials. Do you think that's something that we as academic and community oncologists are going to really have to get behind and push, or are there action steps that we'll be able to take forward?
Look, I appreciate what the FDA is doing, and to me it's an invitation to do what's really what we ought to be doing, what's right to do, and that is to really write the studies that will be including the patients that we have to treat. So you heard, our wood fire, you hear, the patients that come up to the podium. A lot of these patients don't qualify for clinical trials. And the patients that are part of trials, they're very selected. They represent, I think you said 6% or so of the population. I mean, there's a huge gap between what we have in clinical data and then what the real world experience is. And real world experience matters, because if you want to say how a community doctor or really even an academic doctor is going to use a drug, it's going to be based on the trial, right, the level 1 evidence, and it's going to be based on their experience. And if we have no insight into that experience because we don't study it, then how are we going to know if what we're doing in these trials is really practical? These pragmatic trials, I mean, it's not just the feel-good thing to do. It's really the missing information that you pay millions of dollars for retrospective data that's not nearly as good. So, to me, I think it's money well spent to understand really what we're missing when we think about how these regimens actually apply and are ultimately used or not used in practice.
Thank you to the panel. It seems to me that the new guidelines are also to improve diversity in our trials, and one of our strengths is our cooperative group trials. Some of the lessons we've learned from pedigree, for example, is when general oncology practices write us into the pathways. Sometimes that gets also uptake in terms of clinical trial accruals. Can you share a bit about how you all think about pathways and trials on your pathways, and also how can community oncologists and academicians, academic sites work better together?
Sure. So yeah, I think that's a good point. We haven't, all of our different sites at Sarah Cannon have different ways they integrate research trials into their EMRs and pathways. Interestingly enough, in Nashville, we did not do that, but other sites have done that. What I will say is, I think when we talk about diversity, we also need to take a step back and understand that all the conversations that we've had about how do we bring these populations into trials has always revolved around finances, money, opportunity, advertising, access, and how we talk to patients. But one of the things that we don't always talk about that I think I'd like to elevate here today is that all of these, as we talked about on one of these slides, these phase 2 trials now have tons more study visits, tons more study involvement, and ever-increasing deviations because of the infeasibility on a real-world person going on that trial. If we're going to talk about capturing these patients that don't have true access, like some of the other populations, we have to make it easier for them. 8-hour PKs on phase 2 trials. This is hard for working families. This is hard for people working 2 jobs, hard for people taking the bus. So we also have to build in some flexibility into our regimens outside of phase 1 so that we can capture these populations that don't have the freedom to just sit in a clinic all day every week. So I think that's a big thing that sometimes gets missed in some of these conversations. But I do think we can be better about how we think about elevating trials into EMR access. We're actually working on that across our country at our sites, and obviously I would hope our community colleagues outside of SCRI are doing the same thing. And I don't know if Dr. George, you have any thought about how to build in registration?
Yeah, that's a great quote. Look, I've done some studies, not in kidney, but in prostate cancer with race-specified cohorts, and we've learned some things from those studies. I think one of the key things is just that, really to minimize the data to what we actually need. And when we're using drugs that we have a pretty good safety profile in already, we don't necessarily need to collect a lot of safety information. In our cooperative group studies, we typically only collect grade 3 to 5 toxicities. So we can do that on a much more routine basis when we have agents and regimens that we're comfortable with. The number of visits can be cut down. Physical exams that we do over and over and again. A lot of visits can be done virtually through Zoom and whatnot now. There's just a lot of things we learned during COVID that we can live with that now we need to apply on a routine basis in our studies. And I'll tell you, I think that it does take more time to accrue patients who are from disadvantaged backgrounds, because we do have to figure out all these individual hurdles that Ben just brought up. So recognizing that and building in separate cohorts for these patients so that when you're dealing with competitive accrual, they don't get shut out. There's time to accrue these patients. There's incentive to accrue these patients. There's support to accrue these patients. And recognize that even though that may not necessarily be in the upfront population analysis, it can be in the total intention to treat analysis. And it's important that at the end of the day, we have data in these populations. So I think, again, we just need to think differently about how we can be inclusive for these patients from the current designs that we do.
And we're running a little bit behind, so I apologize. I'm going to go ahead and stop the session. Thank my colleagues here, Dr. Bhupathi, Dr. Gramese, and Dr. George for a great panel, and look forward to the last session.